Good morning and good afternoon to those who've joined us. We're just going to wait a couple of minutes before we get started. I see several people still logging on. Great to see so many participants logging on. We're still just a minute after the hour, so I'm going to let a few more join us before we get started here. All right, we're going to go ahead and get started. Welcome to all who've joined us for the first of a 6-part series on substance use. Today's talk is going to be around why we should care about substance use in patients with HIV. I am the moderator, Ellen Eaton, joining you from UAB with my colleague, Dr. Sandra Springer, who's joining us from Yale School of Medicine. Today's training is to partly satisfy a new requirement from the DEA, which requires that we complete 8 hours of training on substance use disorder in order to obtain or maintain our DEA registration. As you can see here, the IAS-USA has a resource center specifically centered around this new requirement. We have 2 talks that are in the works for today and then September, and we'll have 4 additional talks that will help you satisfy this training requirement. As you can see, you're here at the first talk, August 22nd. Dr. Springer will also join me again in September, and then we have episodes 3 through 6 that you can see here, all centered on substance use, HIV, and related risk behaviors. Also, a reminder about the National Substance Use Warm Line. I often forget this myself. This is a cost-free, confidential clinician-to-clinician teleconsult that is staffed by addiction medicine and HIV specialists, physicians, pharmacists, APPs, as you can see below the phone number and the hours of operation. So a really good resource to write down for your team. A reminder of the content on the web board, members along with their financial relationships here, and financial relationships of myself, the moderator, Dr. Eaton, and Dr. Springer, who's our presenter today. We have CME information here. IAS-USA is accredited by the Accreditation Council, and you'll see here that this is a live activity for a maximum of 1.25 credit hours. And you can see the additional CME credits for various groups below. Grant support, we certainly want to thank our supporters for allowing us to share this important substance use education. All right, just some housekeeping. As you navigate this activity, there will be poll questions in Dr. Springer's presentation. You'll see a separate window with a polling question. You can select your response, and you'll see responses displayed after the poll has completed. Remember that for your questions, submit them in the Q&A session or in the Q&A box. If we're not able to answer all of your questions, we apologize in advance. We also have printed off a lot of your questions that you sent in advance, so we're hoping to get to those as well. For the chat is open. This is a discussion with other attendees, but again, if you're wanting to submit a question to be addressed by Dr. Springer or myself, please submit that in the Q&A section. All right, and now we'll turn it over to Dr. Springer, who's going to be presenting on substance use disorder and why we should care about substance use in patients with HIV. Dr. Springer, thanks for joining us.
Thank you, Dr. Eaton. I'm going to just get this into PowerPoint or into the present. There we go. Thanks again, and it's really a pleasure to be here and also have Dr. Eaton here with me to moderate this session. So as Dr. Eaton said today, that we're going to talk about why you should care about treating and first identifying substance use and substance use disorder in people who have HIV, but also are at risk for HIV. And then the next session will be as Dr. Eaton will present on how you would do this. So these are my financial relationships. So the learning objectives from this particular session are hopefully that upon completion of this activity that you'll be able to describe the impact of substance use and substance use disorders on HIV risk and outcomes, be able to screen patients for substance use disorders, and identify evidence-based treatments for substance use disorders. That, again, more of the treatment will be discussed in the second lecture that Dr. Eaton will be giving. So we're going to start out with a pre-test question. The answers will be at the end of this lecture, but we're going to start out with a case, a 46-year-old man who's admitted to the hospital for left-sided weakness and slurred speech and is found to have an acute right corona radiata ischemic stroke. The lab values on admission are a CD4 count of 127 and an HIV viral load of 18,000 copies. He reports that he was diagnosed with HIV 7 years ago, but he never sought care because his wife was sick. However, his wife recently died. So after being seen by an infectious disease consultant, the patient is agreeable to start a combination tablet of bictegravir, tenofovir, alafenamide, fumarate, and emtricitabine, and he's discharged to inpatient rehabilitation for physical occupational therapy. And you can see, I'll give you a moment to answer the question. Which of the following could have prevented this patient's advanced HIV? A, early HIV diagnosis. B, HIV pre-exposure prophylaxis counseling. C, integrating substance use and HIV services. Or D, pharmacotherapy for tobacco use disorder. Oh, here's the rest of it, sorry. After returning, on his 7th day since hospital admission, the patient developed somnolence and altered mental status, and the medical emergency team administers naloxone, and the patient's returned to his usual state of health, and he reports insufflating fentanyl he received from a friend at a bus stop. So this will then you can answer those questions, that one question. So I'll move to the next question. So this is here's the poll data. Looks like 71% answered C, which is great. We'll talk about that later. So the second one, similar CD4 count and viral load. The man who is similarly is admitted to the hospital for the same symptoms, and he was successfully resuscitated. What's the next best step? A, refer him to methadone clinic. B, offer him buprenorphine or prescribe long-acting naltrexone. Or D, none of the above because he's still on morphine for headache after his stroke. And polling responses, yay. So 74% of you answered B, offer him buprenorphine naloxone now. So it's good news. So we're just going to quickly overview the MATE Act. Then we'll go over the EPI of substance use and HIV and substance use and HIV prevention, and then the importance of screening for substance use disorders. And we'll give you examples of how you can not only screen, but actually diagnose substance use disorders in your clinic. So before we go through that, we have some more polls. Are you aware of the new requirement for all DEA registered practitioners to complete 8 hours of continuing education on substance use? So A, yes, I'm aware. Yes, I'm aware of the new requirement, but have not completed the entire 8 hours. Or C, no, I have not heard about this new DEA policy. So if you could answer that, that would be great. And about 63% were aware but haven't completed the entire 8 hours, and about a quarter of you have completed the 8 hours. Another poll question: were you certified to prescribe buprenorphine before the passage of this MATE Act? A, yes. You were certified and actively prescribing to patients when appropriate, or B, you're certified but not prescribing to your patients, or no, you were never certified to prescribe buprenorphine. And so this is really good to know. So about the majority have not been certified to prescribe buprenorphine who are on, who answered the question. So this lecture and the next two, I think, will be really great. Are you familiar with the current DEA guidelines on prescribing buprenorphine? A, yes, you're familiar with them and you've started prescribing under the new guidelines. B, you're familiar with but are not fully confident on how to prescribe buprenorphine to your patients, or no, you're not familiar with the new guidelines at all. And again, it's looking like a majority are not familiar and not prescribing, not confident. So I think this is the last one. What is your primary reason for pursuing education on substance use disorder management? A, it'll be useful in your daily clinical practice. B, the education is required by my institution. C, the education is required by the DEA to acquire and maintain my license. D, just general interest. All of the above for E, or none of the above for F. And it looks like a good mixture here, but 31% say all of the above. So good to know. So just a quick overview. Many of you, I assume, are aware, but the data waiver, the X waiver was abolished in December of 2022, meaning you don't need to have a special X on your DEA license to prescribe medications for treatment of, in particular, opioid use disorder, so controlled substances, importantly here, buprenorphine. And then new or renewal DEA registration. So if you already have your DEA and you either have been prescribing buprenorphine, have your X, or you would like to complete now, you'd like to continue or start treatment, excuse me, which many of you on this call are seem to be in that boat, then all you need to do is complete 8 hours of training on substance use disorder treatment, including opioid use disorder treatment, to fulfill those requirements. So this is one of the 8 hours. And so we have this whole series, as Dr. Eaton said, will fulfill, if you go to every single lecture of the 8 lectures, will fulfill this requirement. That we're not, the IAS-USA is not the only group that is providing, the training for this, but particularly why this one is important is this is designed for clinicians who treat patients with HIV, specifically regarding substance use and substance use disorder diagnosis and treatment. So it's really important to know that. And then as Dr. Eaton had already reminded us, there's a special resource center that you can click on and learn more about that. So why do we care? So first of all, as you all pretty much are all, I'm sure, very familiar with, is sadly, the number of deaths are increasing in the United States at an alarming rate, really starting in the late 1990s from what we call the prescription opioid epidemic that started then. But we did have, an opioid and stimulant epidemic prior to that, but really it took off with prescription opioids. And then around 2010 or so, black tar heroin really kind of kicking off. And then it's really been mainly fueled by fentanyl or illicitly manufactured opioids, but also other drugs. And I think I'd just like to bring attention to the numbers in 2019. We had initially 2017 to 2018, there was a slight dip in the overall reporting of deaths in this country, but really 2019 to 2020, and then onward to 2021, and then the early data from 2022 is showing, and now into 2023 is showing this continual rapid increase in deaths that are occurring in this country, sadly, from overdose deaths. And this is showing you the type of drugs. Again, the gray line, mainly, you can see that's really remarkable stark increase related to synthetic opioids. So illicitly manufactured fentanyl predominantly. But we can't forget that other drugs are causing significant amounts of overdose deaths, including a stimulant. So in yellow, the psychostimulants, predominantly methamphetamine, cocaine, which is our main stimulant in my state of Connecticut, but also a combination of drugs, benzodiazepines and other drugs. And really heroin has been decreasing. It's really hard to find heroin on the streets right now. So we're going to shift a little bit. And I always like to talk about this, and many of you who are on this call, we can't really forget that early HIV epidemic. Really, in the Northeast, we were seeing predominantly driven by heroin and cocaine use, mainly in Black and Latinx populations, many who are unhoused, but the HIV prevalence rate was very, very high. And this was just one demonstration of that in New York. And then we know there were multiple things that led to a reduction in deaths, predominantly the Ryan White Care Act, obviously protease inhibitors being added to nucleoside reverse transcriptase inhibitors, but also syringe service provision, and importantly, methadone for treatment for opioid use disorder. Excuse me. But it's not then surprising, right, that we know that substance use is directly linked to increased risk of acquiring HIV. And then among those who do have HIV, that ongoing substance use and all substance use, there's data to show, interferes with the HIV care continuum that can then lead to poor adherence to antiretroviral therapy, increase in the viral load, and then potentially if there's continued risk behaviors, either sharing injection drug use equipment or condomless sexual intercourse, potentially transmitting HIV to those who are uninfected. And it's not just opioid use, although we'll be focusing a lot on opioid use, but we have to recognize that all substances, and this is a slide showing you from older data, can impact the lack of maintaining or achieving viral suppression in those living with HIV. So alcohol use disorder is quite common. And then as we know, the stimulant use disorder, methamphetamine, which is a major problem in most of our states. And like I said, cocaine is the major one in the Northeast still. And, this is older data, obviously, from the CDC. We know that the major transmission categories are among male-to-male sexual contact and heterosexual contact. But it's important to look at the trajectory. So injection drug use had like a pretty much stable line, a little bit reduction. And then we saw like in 2017, a slight increase in uptick of HIV occurring among people who are injecting drugs in this country. In time, we can't forget when the first early epidemic was shown, related initially to prescription opioids in Indiana, which was in 2015, when we saw in April of 2015, 135 newly diagnosed people. And it was really related to this new a long-acting prescription opioid, oxymorphone. And importantly, 45% were female. And then this is from the Kaiser data, that it was really found that this new epidemic was associated with a particular area of Scott County, Indiana, the majority of which were associated through sharing injection drug use equipment, This is the paper from the New England Journal and by Peters and colleagues in the CDC, really doing contact tracing. And we can't forget that in addition to sharing injection drug use equipment, there was also condomless sexual intercourse occurring in the setting of this that led to the marked increase in new cases. So by November of 2015, there were 181 cases. This was just a slide a long time ago that I put together, really just from data from the newspapers and other reports, but really showing this marked increase in new HIV epidemics occurring among people, I would say not just injecting drugs, but using drugs. And we'll note that several of these states are Medicaid expansion states too. And so really important to know that, that we still have a lot of work to do. And importantly, I'll talk about the Massachusetts outbreak that occurred in 2018, but really moving from injection of prescription opioids to fentanyl, heroin, and also stimulants. And this was the evaluation in Massachusetts. And the reason why I even comment on it, it's a state just north of me, Medicaid expansion state, has an excellent healthcare system in general. And in Lawrence and Lowell, there were two mill towns only 30 miles west of Boston. And really, we started seeing a stark increase in new HIV cases occurring among people who are injecting drugs, which is in the lighter blue. And when we looked at that a little bit more, and the CDC looked at that more, really was related to injecting opioids, mainly fentanyl, as well as stimulants, and sharing injection drug use works. And at that time, the mayor had put a moratorium on syringe services. And there was really an association among those who were being released from the carceral system, having difficulty in accessing antiretroviral therapy after release. And so this idea that individuals might have been suppressed while they were incarcerated, but then upon release, lack of maintaining viral suppression, and then sharing injection drug use, as well as having condomless sexual intercourse. So when we think about this HIV care continuum among the people that we know who do have HIV, we really want to achieve viral suppression. We want to know, in particularly those who are using drugs, how are we doing? And we're all familiar with the US ending the HIV epidemic plan, really grounded on excellent science, showing that if we can diagnose everybody, get everybody who has HIV on antiretroviral therapy, achieve viral suppression, and those who don't have HIV, who are at risk, to offer them pre-exposure prophylaxis, that we could hopefully reduce the number of new infections. And here the goal is to reduce by 90%. At the time was 10 years, so it's really for 2030. And so we have a lot of work to do. But when we look at the population who is using drugs, and mainly those who are injecting drugs, that we have a long way to go. So if we want to achieve 100% to have viral suppression, and also help with other harm reduction services, we really need to improve our work. So this is estimating in the red box for those who identify as having HIV through injection drug use, only 56% have been virally suppressed. When we think about prevention, this is also data a little older, but data from the CDC showing among people who inject drugs, the majority are men. But I still important to know that 27% identify as women. And we look at ages, again, from the 2018 data, sadly, the majority of new diagnoses are occurring among younger folks, 25 to 34, who are injecting drugs. And when we look at other possibilities of how to prevent, syringe services are, well established to reduce HIV transmission among those who identify as injecting drugs. But unfortunately, the data again here showing that 32% are still reporting sharing syringes, and again, and more common among younger people. And you can see on the right-hand side that 48% of people who are sharing are reported to be between the ages of 18 and 24. When we look at prevention for pre-exposure prophylaxis, this is older data, but showing again a very small reduction. This was from 2018, a small number of individuals who are on PrEP. And then this is data from a colleague of mine, Irene Kuo, and colleagues at GW, looking at the PrEP continuum among people who identify as injecting drugs in Washington, DC specifically. In blue was 2015, and then in orange was 2018 to see if there was a difference. And you can see it's a pretty abysmal that really very few have heard of PrEP, and very few are taking PrEP. And I can say, unfortunately, the numbers are pretty similar among those who inject drugs now. This is just a summary, quick slide that, we're recommending in the EHE plan to rapidly initiate antiretroviral therapy and also identify those who don't have HIV to, hopefully get people on PrEP as soon as possible. There's implementation issues and other problems, but just to remind us that it can occur. We can do this. And in San Francisco, and those 51% who started, who had substance use disorder were able to achieve viral suppression, study by Coffey and others in 2019. And then although it wasn't specific to substance use disorder, we know that unless rapid antiretroviral therapy can occur and lead to high viral suppression rates. So let's talk about screening. You want to know if patients are actively using drugs or alcohol, and you want to be able to screen so that you can hopefully help them. So the first and foremost is really taking a non-punitive approach to this and asking everybody the same way, same questions, and hopefully when you ask those questions, if they do report a positive screen, that you'd be able to offer them treatment in the moment. So expert screening and brief intervention and initiation or referral of medication treatment for substance use disorders. So it's occurring all over. We do it in jails and other hospital settings and community settings, but also harm reduction services. You could do it in the emergency room, in your primary care clinics, in your specialty care clinics. So why? What is this? So, for diagnosing a substance use disorder, typically psychiatrists, psychologists, we use the DSM-5, the Diagnostic Statistical Manual, and it's currently the 5th edition. And it's important to know that there's no longer substance abuse or substance dependence anymore. It's substance use disorder. And all you have to have are 2 or more symptoms among these 12 among these symptoms that are listed here to meet criteria for a substance use disorder. The severity is really important. So there's severe, mild, moderate, and severe. And the reason why that's important to know is moderate to severe would allow you to treat, say, for opioid use disorder, medication treatments for opioid use disorder. So not only do you need to diagnose what form, if they have a substance use disorder, but you need to know the severity. So 4 to 5 symptoms would make moderate criteria, and 6 or more meets criteria for severe. And so they're listed here. There's 4 related to loss of control, 3 related to social problems, 2 related to risky use, and 2 related to pharmacological problems. So you don't have to have evidence of tolerance or withdrawal anymore. We used to for abuse and dependence, but those could be 2 of the criteria that you can see here. So that might be really easy for some of us who have memorized all of those, but sometimes that's not. So we have screening tools that can help us determine if that person might have a DSM-5 substance use disorder. And these are just a few of them. This is not at all a comprehensive list, but we tried to make sure we put some in here that are free. So you can see on the bottom, the audit, the alcohol use disorder identification test is the World Health Organization most recommended tool for alcohol use disorder. 10 items, well validated, and it will give you a severity score, which can help you in the next lecture when Dr. Eaton presents. We'll talk about how that can help you treat alcohol use disorder. But the first one, the NIDA Assist, is well known. It's just one screening, well, it's actually 2 screening questions, but in the past year, how often have you used the following? Prescription drugs for non-medical reasons or illicit drugs, they use the term. If they answer once, that is a positive reflex. So you would want to then go into more detail to ask about whether they meet criteria for a substance use disorder. So that's easy. You can just build that into an electronic record system, or a quick question you can ask in your clinic. You could then go to the full NIDA drug screening tool, the full assist, and the link is there. Or you could use another tool. So I'm giving you examples here, but one is the rapid opioid dependency screen that we created a long time ago. It's free, less than 3 minutes, non-clinician can use, and you can get a diagnosis of what used to be opioid dependence, which is similar to moderate to severe opioid use disorder. So this is just a schematic. They screen yes on saying they've used opioids in this particular situation, could be stimulants, but we're talking about opioids here. You immediately reflex do the rapid opioid dependency screen, and they score a 3 or more, which means opioid dependence. You can then, when you know that will allow you to offer treatment. And that's the goal, right? We want to reduce overdose deaths. We want to be able to improve HIV outcomes and other things. I just put this in here for you to know that there are now 2 new diagnostic tools that are now clinically available as of August 16th that our team here at Yale, and as well as colleagues at NYU, created that are free. One is now a rapid opioid use disorder diagnostic tool on the left, and the other is a new rapid stimulant use disorder diagnostic tool on your right. Those are now validated to the DSM-5, and they will be able to quickly tell you if they meet current criteria for moderate to severe opioid and stimulant use disorder. So the other one had been for DSM-4, but they are now available as of August 16th. And it includes fentanyl now, which the other one had not. And so just to bring your attention to those. And again, they were validated for non-clinicians. You can, as a clinician, do them as well. But if you had a person waiting in the waiting room and had a tablet or some other thing, they could quickly help them. Anyone can help them do this. We do these in jails, prisons, and community and substance use and HIV programs. So like I said, screening. Once you screen, you diagnose, you can then treat, right? So for this, we're talking about opioid use disorder. And again, Dr. Eaton's going to talk about this more in the next lecture system. But I just we're really focusing on opioid use disorder here because this is directly related to the X waiver removal. So we have 3 effective medications in the United States that are all available: methadone, buprenorphine, and extended release naltrexone. Methadone you can only prescribe for the treatment of opioid use disorder if you're in a licensed opioid treatment program. You cannot do that in your own clinic. So that's important. So you may have to refer, or unless you're in one of those programs, then you could prescribe there. Buprenorphine, there's now multiple formulations, including a now injectable form in the abdomen. And then there's also another injectable form that'll be available next month, which is weekly and monthly. And then there's an implant that lasts 6 months, as well as the daily oral form. Very few, if I would say no interactions with antiretroviral therapies. They all 3 medications have been shown to reduce HIV risk behaviors. They all reduce overdose, which is important. And we'll show you in the next lecture series that 2 of the medications, buprenorphine and extended release naltrexone, have actually been shown to improve HIV viral suppression rates among those who have HIV. An extended release naltrexone, also an injection, no special training. It's an opioid antagonist. It's a blocker, so think of it as a long-acting naloxone. Is also FDA approved for alcohol use disorder. There's no overdose or diversion concerns in this because it's not an opioid, but it can reduce overdose deaths and can reduce HIV risk behaviors. So this is just a summary. We don't have time to go into all the data. But really important to know, the reason why you want to be able to potentially offer treatment right in the moment, if you have somebody who's willing and has a diagnosis of opioid use disorder and would like to start treatment, buprenorphine is the best treatment. you could offer it in the moment and you could save a life, because any use of an opioid could increase the risk of overdose and death. And from an HIV perspective, we can help an individual adhere to their antiretroviral therapy and hopefully maintain or achieve viral suppression. And this is just a summary slide that there's several studies that have shown that when you integrate treatment for opioid use disorder, medication treatment, buprenorphine, extended release naltrexone, you can improve the likelihood of improvement of HIV treatment outcomes, viral suppression, as well as, of course, opioid outcomes. So we will be talking more about the actual treatments for substance use disorder in the subsequent lectures, but we just wanted you to come away with this idea of why it's so important. So, it's a very common substance use, and unfortunately, substance use disorders are incredibly common among people who are living with HIV and at risk for HIV. There is a substantial amount of data to show that if we can identify substance use and substance use disorder and treat substance use disorder if they don't have HIV, we can hopefully improve the likelihood of pre-exposure prophylaxis to prevent new infections, but also among those who have HIV, if we can help individuals stay on treatment, stay adherent to treatment, and maintain viral suppression, we could reduce transmission of HIV to those who are uninfected. And I think it's also really important that what we came away here with is that you know how to screen, you know how to ask the questions, you know how to potentially offer a quick diagnosis, or if you don't have those tools, having somebody that you work with who potentially can help you with that. And if you don't feel yet comfortable with treating substance use disorder, that identifying somebody that is within your group that can do that. Because the worst case scenario, right, is you identified or you're aware of someone having an opioid use disorder, you had someone right there who's willing to start, but then you say, hey, you know what, I can't do that right now. I'm going to refer you to another provider, another clinic. They can see you in a couple of weeks. The problem is of course, the craving for opioids and other substances, whatever the substance is that they're maybe have an addiction to, is prevalent, and it's out there, and the likelihood of them using is very high. And so the risk of potentially death is significant. So if you can offer treatment in that moment, you're potentially saving a life right there. So we had these post-test questions. This was the gentleman that we had already talked to you about. And the question was, which of the following could have prevented this patient's advanced HIV, early HIV diagnosis, HIV pre-exposure prophylaxis counseling, integrating substance use and HIV services, or pharmacotherapy for tobacco use disorder? And I think most of you answered this correctly, but we had, I don't know if the polling is still going on. Yay. Okay, so it's 95% saying C, integrating substance use and HIV services could have prevented this. And that's true. And that's the whole point, right? We're trying to come across is that if you could screen, and it can be anywhere. It's in the hospital setting. We have a study going on in the hospital setting, and I can say 98% of the patients with opioid use disorder had a negative HIV test, but no one was offered pre-exposure prophylaxis. And very few are offered, unfortunately, opioid use disorder treatment. And so it's a reachable moment. And then we had, and this is just describing that response. And yes, tobacco use disorder was one of the questions that we could treat, and definitely agree with that. There isn't any direct data that we're aware of right now that would contribute to improving HIV treatment outcomes, but maybe there's a study going on right now. And again, one of the lectures that we're going to have is devoted specifically to nicotine and tobacco use disorder treatment among those with HIV. And then this was the next question that we had asked in the beginning. about the same gentleman. And after he overdosed from fentanyl, what was the best next step? And A was referred to a methadone clinic on discharge, offering buprenorphine combination naloxone, now prescribed long-acting naltrexone, or none of the above because he's still on morphine for a headache after a stroke. And I think most of you had responded correctly. Yeah, so there's the majority saying offering buprenorphine. Some said long-acting naltrexone, and that's possible. You could do. The only thing about the naltrexone is because it is an opioid antagonist, an opioid receptor blocker. If he is on a form of treatment, opioid pain medication like morphine, you would be displacing that, and he could withdraw. And also, if he's acutely using and acutely in need of help, naltrexone is not a treatment for withdrawal management. It's really buprenorphine and methadone are the treatments. And so this is just a response to that. So I think that was the end. We did it pretty quickly, but if we have any questions, we can take the time to do those now.
Yes, thank you so much. That was wonderful. I always learn from you, Dr. Springer. Lots of great questions. I am going to start with the Q&A, and there are several that are overlapping with questions that came in before the talk. I'm just going to start in order that they came through. This initial question is around someone who works in a state health department and requires local health departments to do substance use screening every 6 months. One department maintains that they have been seeing their clients for more than 20 years and they know who needs treatment and who does not. It seems to me that they do not realize the circumstances that change. And how would you respond to their objection to administering the screening tool? So I think we all see this in community partners who say, either we don't have a problem or our problem is under control, when the data suggests that the problem is very much not under control. So how would you approach communicating with this local health department site, Dr. Springer?
Yeah, no, it's a good question. I think you really already responded. Unfortunately, we're not seeing an end in these epidemics. And sometimes if you don't, people change, and it's also how you ask the questions too. So the concern is you can ask any question, but how do you ask it? So you're not using drugs, are you? You already said no. We've been through this before. You've responded no. So it's how we ask the question. You keep it open, allow someone to answer without being punitive. We're more likely to probably catch potentially a new substance use or substance use disorder, or say somebody who's been hasn't used for a while and has restarted use. And I think I see this a lot in my clinic. It's at the VA, I see patients at the VA in my ID clinic. And I think there's been several patients who might have not been using or had been in treatment and then recently restarted. And so we always talk about, I always ask them every time. So I think it's important to keep an open mind and ensure that all the staff have training in how to ask these questions, and then how to respond to someone who might have restarted. There's a lot of shame. I think people have to understand there's already a significant amount of stigma. But then on top of that, if we think about how individuals who use drugs have been treated, reporting to somebody that you've started using again, it can be a very difficult thing for someone to share. And so trying to keep that open, explaining to people, unfortunately, it is a chronic relapsing disease, that no matter where you are, if you're craving or if you're using, that there's treatment that's available for you.
Yes, I totally agree with you. I just wanted to plug patient reported outcomes. I think what we all know is that our patients have a desirability bias. They want to make us happy as their providers, right? They may not want to disclose that they've started smoking crack since they saw you last. So anytime you can have a paper tool, an electronic tool, we know that patients are much more candid and honest to a tablet or a piece of paper asking some of these questions. And then in our next talks, we're going to talk about comprehensive screening, not just substance use that we think of with illicit substances, but alcohol and tobacco, right? I think I see more of that than anything in my clinic. And Sandy, do you use in your clinic any kind of standardized tablet or paper, or is it just physician delivered screening?
Yeah, I think it varies, but I just know the question, so I do the audit for alcohol, and then I do the quick NIDA assist question just for other substances, and then we go into if it's opioids, then I can do the quick screen for the opioid use disorder, which was the RODS, and now the new tool that we devised that we created. But yeah, no, they're like the VA healthcare system has certain measures, but there's really not been a unified that I can see healthcare system that puts in rapid opioid use disorder or stimulant use disorder diagnostic tools. I've seen quite a few who use alcohol and then ask about tobacco, but I don't really see that very much. But I don't know if it's something that I would like to see all healthcare systems do.
Absolutely. And along those lines, we have two questions around how people can access the Yale opioid use disorder and stimulant screening tools. And a similar question, where can we access the new validated rapid screeners, came up just following your talk. Do you have an easy landing page or website that you could refer
Yeah,
people?
actually that link that's in the slide brings you right to the paper that was published, and in the appendix are the two measures. So they're free. When we created them, we wanted people to use them with the hopes that people, would use them and then hopefully offer treatment. Now, stimulant use disorder, as you will talk about in the next session, we don't have really an effective medication yet to treat stimulant use disorder, but you'll talk about contingency management, other behavioral therapies. But the reason why we would want to know, right, is that we could offer them treatment, and that ongoing stimulant use can interfere with not only HIV treatment, but can also interfere if they have opioid use disorder, interfere with their ability to maintain or stay on buprenorphine treatment. So, and then also harm reduction services, right? Syringe service programs, drug testing, other things. So, and then of course, don't forget naloxone. But yeah, so they're free. And if you just want to email me, I can also send them. But the link in that one slide has the actual link to the paper and the tools.
Great. And as a reminder and available in the chat, this recording will be available within 24 hours. So people who want to refer back to it. One question that came up twice, the differentiation between opioid dependency and opioid use disorder. And I see a lot of patients who are on that spectrum, and I think they can also go from one side of that spectrum to the other. How do you differentiate clinically in your clinic, and how may you treat them differently or not in terms of clinical care?
Yeah, so we no longer use the terms dependence or abuse. So the DSM-4, you had the criteria that you had to have opioid dependence in order to be offered treatment. Now it's opioid use disorder. So moderate to severe opioid use disorder is what we would now refer to as what used to be opioid dependence. So anyone who, the current recommendations are you have to meet criteria for moderate. So, 4 or more symptoms of opioid use disorder to require medication treatment. I have a feeling that that's probably going to change, but right now that is what the criteria are to prescribe FDA approved medication treatment. So buprenorphine to treat opioid use disorder. And I think it's important to ask, one thing that I do in terms of somebody who might be not actively using, but meet a criteria for opioid use disorder, I do a craving question for everybody. I ask on a scale of 1 to 10, how much are you craving? In this case, opioids. 10 being if I had drug right here, would you use it? 1, maybe not thinking about it at all, and find out where they are in their craving spectrum. And then coaching and counseling them that if they start feeling that craving to increase, that's a high risk of use. And so if they are on a form of treatment like buprenorphine, do they need another higher dose? Or if they're at the max dose, is there something else going on? Or if they're not in treatment, that would be a great time to contact me, or I give them information on services and wherever they live that they could get treatment. So I use it like we used to do the pain scale, and it really is associated. Craving is highly associated with increased use. And it can be craving, psychologically craving. It could be seeing somebody who walking by, place that used to buy drugs or use. It could be any of those that can stimulate the likelihood of use. So for me, it's more predicting the likelihood of use. And if I can prevent relapse, that's why I'd like to have them on a form of treatment if they're willing.
Great. And a question that came in ahead of time that is a similar theme is that chronic pain patient, and this is, I think, where I see that spectrum, chronic pain on opioid agonist for pain control for long periods of time. And this question, we may not have enough history for you to give one suggestion, maybe a range of options on how to manage. I have a patient who's been on the same dose of narcotics for years prior to seeing me. I tried to refer him for detox, but they won't accept him because the medication is still prescribed, yet I can't reduce the dose because he has worsened pain. And I don't know if you see this type of patient or if you have a specialty kind of pain clinic, but curious what's your approach to that type of patient who physically is dependent on his chronic opioid therapy, but maybe you as an HIV provider don't feel comfortable with that dose. I think we're all seeing patients like this as our HIV population is aging, right? I'm seeing a lot of this.
Yeah. It's a good question. Sorry if I had misinterpreted your question before, but this dependence based on their physiologic need for another condition. It is a common problem, right? Pain and opioid use disorder. And one of the ways to predict that is if it's a prescribed amount, are they using more than the prescribed amount? Are they having to purchase opioids off the street to, continue to either is it for pain related or potentially the underlying having an underlying substance use disorder? And it is very tricky. And if you're in a good healthcare system that has colleagues that are pain specialists, we've seen that can be very helpful. But I do want to remind everybody that buprenorphine was originally created as an analgesic, right? It turned out not to be the best analgesic. There are other opioids that were more potent, but we can successfully, and there are several healthcare systems that are doing this currently, co-treating pain with buprenorphine and other medications. And you have to potentially split the dose, maybe it's recommended maybe 3 times a day. So you can treat pain and opioid use disorder at the same time. You can still determine if somebody has an opioid use disorder who is on opioid pain medications through doing the same questions that you would do to identify a substance use disorder, DSM-5 criteria, and it'll come back as a positive. But they still need the opioids for their pain condition. It's just being able to help them in the best way. And then, of course, there's other non-opioid treatments that could be used in conjunction with that. But it can be complicated. But I just anecdotally, there was a patient I can't say too much, but someone who didn't recognize that they stopped the person's pain medications, and the person then used what he thought was heroin, but it was fentanyl, and overdosed and almost died in the hospital setting. And so we have to, that was a teachable moment for the healthcare system, the healthcare provider that we, obviously if you cut off their medication, they're going to go into withdrawal, and they're going to need to reduce those withdrawal symptoms, use opioids. So we shouldn't be doing that. We shouldn't be cutting people off. So if they have a real pain need, you have to, be very careful. And be able to recognize withdrawal symptoms as well.
Yeah, great point. And you kind of mentioned this, but dosing, one question that came in ahead of time, is the dosing once as one time, I'm guessing meaning daily, as opposed to splitting the dose multiple times over the course of the day. And I'm thinking that this is in relation to, I don't have a lot of context there to that question, but could you just speak to how you administer buprenorphine? We know it's long acting. We know it could be delivered daily, but any considerations for more frequent dosing and how you manage that in patients with opioid use disorder?
Yeah, I mean, so it is typically a once a day medication. So for the opioid use disorder itself, usually 24 milligrams, but some people go up to high as 32 milligrams. It's very potent, has a high affinity for the mu opioid receptor. So, no one really goes up too much more than that, as opposed to methadone, which is a full opioid, and you may need to go up. But I typically give it once a day. But again, in those patients that have comorbid pain use disorder, that's typically where we see the split dosing. The other treatment that we're using more now is a long-acting form of injectable buprenorphine. There's one currently clinically available, and then there's another one that's coming. It's going to be clinically available in September, which has a weekly and a monthly formulation. But and that's a once a month injection, and comes in 2 doses, 300 and 100. They're not equivalent to what buprenorphine is, but it's Sublocade is the medication, and that you could use that with comorbid pain. The big challenge, and we're going to be talking about this in the next 2 lectures, is the fentanyl problem. And so we are seeing individuals who may be on a long-acting form of buprenorphine, may be requiring, in addition, other sublingual doses of buprenorphine on top of the long-acting buprenorphine. And I know we'll be discussing that later.
Yeah, good to see these additional options for, administration. I'll be honest, most of my patients with HIV have such chronic pain that it's hard to get them to that daily dosing. And I know it's more convenient in terms of taking it before work, et cetera. But I think the epidemiology of my clinic, which is HIV and opioid use disorder, most of them have a lot that do manual labor, construction, a lot of back pain. I have a fair amount who've had osteo, complications of injection drug use, complicated osteomyelitis, and other reasons that they have chronic pain. So I would say more of my patients are taking it more, or splitting their dose to provide that analgesia throughout the day. But I do recognize that there are certainly benefits of taking advantage of that long acting once a day. And then moving to injectables. And I wanted to get to this question around cost that came up, because I think this is so important for the feasibility of these medications in our clinics. Dr. Hurt messaged, how much do the different forms of buprenorphine with naloxone cost? Are there copayment assistant programs like we have for ART?
Yeah, no, it's a great question. So I live in a Medicaid expansion state, and the Connecticut Medicaid covers all the forms of treatment for opioid use disorder, including the long-acting form of buprenorphine, which can be quite expensive, about $1,800 an injection without insurance. And then similarly, long-acting naltrexone. It is a big issue. One, and it can't be understated enough, is that having the ability to have insurance and have a way to pay for these medications is absolutely critical. And if we, I mean, we just think about HIV, right? The Ryan White Care Act, where, if we didn't have dedicated funds that went to every state to provide treatment for and care for individuals living with HIV, we would, we would not have made the reduction in deaths that we have. The same thing should be true for substance use disorder. Why do we not have coverage for that? And we're not really going to see a reduction in deaths unless we can provide adequate treatment, reduce stigma, and also harm reduction services for all patients. But why, if I have an opioid use disorder, if I don't have HIV, and again, not all Ryan White Care programs are created equal, so some are not providing medication treatment for opioid use disorder, just want to say that. But if I don't have HIV, I'm at risk for HIV, I have to then have insurance or be able to pay out of pocket for treatment for my substance use disorder. And so I don't know, every program has differences, but there are certain formulations, so tablet formulations of sublingual buprenorphine that are less expensive than, say, the film. And then certainly we have the same issues related to injectable forms that, unfortunately, and we have colleagues in Texas doing another research study trying to get access to treatment. If you don't have the ability to pay for those medications, and we could be talking about long-acting PrEP or long-acting androgen, you're not going to see an uptick in the use. And so we can't really, and that's not just something we can fix here, but we do need to try to advocate for patients in your legislature, senators, others, to really advocate for improving access to treatment for all substances, but importantly for medication treatment for opioid use disorder access and payment.
Yes, and along those lines of better access, we have a question about advice on treating a patient through an integrated model that includes mental health, primary HIV care, and substance use disorder. And are there successful models?
Yeah, well, Ellen, you should probably take that question.
Sandy and I met through a program where we were working to identify successful models of integrated care. So I knew she'd appreciate that. But yes, there are several models. I have an HIV clinic here at UAB at our 1917 clinic, where I treat opioid use disorder within our HIV clinic. So it is co-located and integrated in the sense that there's an HIV physician providing the opioid treatment on site. And we do have the benefit of Ryan White funds. So we have wraparound services. We are not a Medicaid expansion state. We do also get some 340B funds. So you really have to cobble together this funding to support counselors and ideally psychiatrists. And we have a peer recovery person who I would highly recommend if you're trying to integrate this type of care into an HIV clinic, having someone with lived experience in substance use on staff. In my state, there is that through the Alabama Department of Mental Health, our peers get certification to be a certified peer support person. And in my opioid treatment clinic, this person is arguably the most important because they provide a lot of motivational interviewing. They provide a lot of adherence reminders and clinical care coordination, referral to inpatient treatment, intensive outpatient care for substance use. So I think having a team-based approach within an HIV clinic or an FQHC is really the way to do it. Just to give you a sense of numbers, it is not overwhelming. In our clinic that has approximately 3,500 patients with HIV, I have about 90 with opioid use disorder who are in care in my clinic at any given time. We know there's a lot of relapse and return to use, so they're not all in care at one time, but we always welcome them back with open arms. And I will say there's a lot of patients who come to their opioid treatment appointment, but miss their HIV appointments. And I think there's a lot of reasons for that. They know that they have to come to receive services like their buprenorphine. They know if they come, they'll get access to our peer support person and wraparound services, mental health care. But I do a lot of HIV care for patients who have been out of care. Maybe they've been in jail, maybe they've been in an inpatient treatment setting. And because they come back for substance use services, I'm then able to check their viral load and refill their ART and screen them for STIs and get them their vaccines and that kind of thing. So I highly recommend that model. And I'm happy to answer any questions about how to implement that type of model in your clinic.
And I was gonna comment, yeah, that was the National Academy of Sciences, Engineering and Medicine study that came out in January of 2020. There's other things coming out going on. But the other models include, going to where people live and integrating in a one-stop shop. So mobile health unit, provision of care, integrating substance use and HIV prevention and HIV treatment. So there's an HPTN 094 study going on in 5 cities across the country, looking at that model. And then another one that we're doing in those involved with the criminal justice system coming out of prison and jail, and like looking as that as a model to potentially provide care. And as Ellen aptly discussed, really, I can't say enough about having peer or patient navigators or community health workers, other individuals that can help a person who may not have ability to get to the clinic or have difficulties with transportation. That has been found to be absolutely critical in helping individuals have care. And there's several states, including our state of Connecticut, I know Texas and Kentucky have passed legislation where community health workers and navigators are now billable services. So you should guys look into that, because that could be actually really critical to helping an individual who might not be able to come into your clinic as readily or is unable to help them with accessing HIV treatment, prevention, and substance use disorder treatment services.
That's a great point. Thinking about ways to, get compensated, compensation for the care we're providing.
Yep.
One question that came up that I just wanted to kind of push back on, you and I talked about ahead of the call, is that someone had heard a statistic that 95% of people who use drugs are not interested in treatment, and how we could address that. And I'm not sure, we don't have a reference for that statistic. That seems very high in my experience. But how would you address a patient who is resistant to substance use treatment? And this came up a couple of times, the patient who comes in for HIV care but does not want to accept substance use services.
Yeah, and I think, I'm not sure where that 95% number has come from. I have not seen that in the literature, but I think we have to remember, and I said this before, how we ask patients and how we, when we're asking them, what is our motive for asking them? So for me as a clinician, I'm really mean, like I want to get you help and I want to offer you help. So we have to be careful with that, but also just remember that not everybody's ready for treatment. How many patients do we have that have diabetes? We go through the whole treatment recommendations, or maybe high blood pressure, and some people are not able to, for various reasons, potentially do the things that we ask them to do. Certain diet regulations, monitoring their glucose, taking their medications, but we're still not going to deny them treatment, right? We're going to still help them. We're going to have them come in. Someone with substance use, they may not be ready for treatment. The issues are being able to ask and offer them, when you're ready, I can help you, or let's look through a list of services. In the meantime, let's talk about safe ways to keep you safe. So if somebody is injecting opioids or using any drugs right now, because fentanyl is adulterating many drugs, as well as xylazine, which I know we'll talk about at some point in the series, but we have to be able to offer people, meet them where they're at. So there's enough established literature to support this hypothesis that you constantly ask if they need help. If you have to educate. So a lot of people may not know that there's effective medications for treatment of opioid use disorder. They may not know about contingency management for stimulant use disorder. They may not know that there are effective medications like naltrexone for alcohol use disorder. So we just have to keep reminding people. But in the meantime, let's talk about how to keep you safe. So yes, do you have a state or do you have accessible syringe services for patients? Can you give them those resources? Do you have drug testing for now fentanyl, but also now there's testing strips for xylazine? Do you have naloxone? Can you teach them on, everybody should be offered naloxone. But, do they have a partner that we can bring in to teach them and safe injection procedures if you are going to use drugs? But in the meantime, if you're interested in treatment, you know where to go. And if you can't access me, here are the resources in your community. That's what we should be doing. I think I do hear that a lot, Ellen, that, people don't want treatment. We don't really know unless we ask people. And just remember how and from what I've seen, and I'm sure what you've seen, and I know other colleagues of mine have seen this, who've taken care of patients with HIV and substance use disorder, the stigma related to substance use in particular, in many ways, is unfortunately far worse than that stigma related to HIV. And we see this in the healthcare system. We see this in the community. We see this from family and other loved ones. So it's our job to kind of try to help and reduce that and say, hey, we're here for you. And I would not at all assume that individuals don't want treatment. You don't know, and it's how you ask and how you offer it.
Yeah. And what's available too, right? I know a lot of the facilities in the Deep South where we don't have Medicaid expansion are offered by faith-based organizations, nonprofits, who often don't use evidence-based models. They do not use medication first. So buprenorphine would not be allowable, so I think in my case, a lot of my patients don't want what's available because they don't have access to some of the most evidence-based treatment that insured patients have. So with that, I'm going to kind of wrap us up. A lot of questions that are still out there are around harm reduction, syringe service policy. I see a question about GI side effects of buprenorphine. I'm going to try to ensure that we address these in our subsequent talks. I think we can save these questions and hopefully get to all of them. If you can return for the rest of the series, we'd love to see you, and thankful for your time and that you're willing to join us in this really important patient care initiative. So if we can go ahead and share those final slides, I can complete them. Great. So just a reminder about how to claim CME credit for this. Also, your feedback is really important to us. Let's see, can we advance that? Great. And a reminder that this is just the first of a 6-part series. Please look at our resource center, return for additional talks that'll be provided by myself, Dr. Springer, and a whole host of experts from across the country will be joining us. More detail here on how to register. Also, an additional reminder about that national free confidential warm line. So if some of you are starting to treat opioid use disorder for the first time, you likely are going to have questions. You may need a peer mentor or an advisor to walk you through some of your concerns. This is a great way to get access to a specialist. And a reminder about a long-acting ART webinar coming up in November. Really great data here on long-acting drugs for the treatment and prevention of HIV. So please mark that on your calendar. Some additional data on upcoming speakers that you can expect in the next year. A few more, doxy-PEP, cardiovascular prevention. So great content coming up in the next year. RSV, flu, HIV 101. All right, thank you for participating. And again, we hope to see you again. And thanks for joining us.
Thank you.
Thank you, Dr. Springer.